doing next to nothing. So this tropical and travel medicine seminar tonight, we have fantastic residents at the University of Minnesota in our program, and we thought it would be great to give the residents a chance to showcase some of their interests and background in the stuff tonight. And so in the back of the room, you guys will see Ryan Fabrizius. He is our one of our two chief residents. Shefali Gandhi has left and is now in Arusha, Tanzania, at Selian Lutheran Hospital. And Ryan, we're very excited to have back. And so Ryan is actually going to be taking the lead on kind of emceeing for the evening and also presenting a case on his own. So Ryan did his Med-Peds residency with us here at the University of Minnesota and was one of the Global Health Pathway residents, and currently working in the chief resident spot. So Ryan, I'm just going to go ahead and turn it over to you.
Hello, everyone. Thanks so much for coming out. Sorry about the event parking thing. It's disappointing. But the food is really good, and the presentations will be very good. Tonight, we want to try out one new thing. If you're avid in the Twitter, we were going to try out live tweeting. So it's at #UMNTTMS. So we hope to maybe roll out some tweeting for other areas of global health. But this is the first time we're officially trying it out. So if you have the app and you have an account, follow along or contribute your own thoughts. Don't say anything mean. So we're going to go ahead and get started. And our first speaker is Adriana Dawan. Am I saying it right? So she is unique in that she's from New Mexico. So she did most of her medical training there. And we're happy to have her here as a Med-Peds resident. And I believe, where are you going with IOM? Jordan, yeah. So that's another very unique opportunity she's taking, which is amazing. So I'll hand it over to Adriana. I think your presentation is up here. You can take this if you want. You can walk around.
That won't be necessary.
And this is a pointer.
Okay. Which one's? Okay. Can you guys hear me okay? Weird. Okay. So I'm Adriana, everybody. Heard that lovely introduction. So this is kind of a teaser. So I know Zika virus has been in the news a ton, and there's a ton of really interesting stuff coming out about it. It's apparently a long-standing viral illness that most recently got identified and has been found to have some really interesting associations with maybe microcephaly, some other really unusual stuff coming out of South America. But in actually kind of preparing for doing one of these updates, one of my colleagues took a special interest in the topic and is actually going to be presenting on it next month. So please return next month for more on Zika virus, and hopefully there'll be more details about it in the news and other good stuff to complete that part of the talk. So because we're talking a lot about infectious diseases today, and while I really, really enjoy infectious diseases and was hoping to pick out something really specific to talk about today, since we have a whole day dedicated to it, I thought I'd talk about something non-infectious and see if I can make it as interesting as all the stuff we'll talk to you about later. So this is a picture that came out relatively recently. So this is actually of, I think it's Mumbai. This is India. And this is a picture that demonstrates all of the horrific air pollution that's going on right now and is getting a lot of really interesting press lately, especially in some of the developing countries. And there's actually a whole lot of interesting evidence mounting about the health effects of air pollution and some of the really interesting findings. And there's a lot of stuff all the way from really detailed research, lab-based pathophysiology about how these things are happening, and then some really interesting stuff coming out on whole population health changes and big effects on the scale of like 7 million people per year dying prematurely because of air pollution effects. So I thought I would touch on this today. And try to take that big view. So I thought I'd talk just at the very, very basic level a little bit about the different types of air pollutants. So there's kind of 5 big ones that we talk about and that it's addressed in the literature. And the most important one is particulate matter. And so you hear about people talking about 10 parts, or 10 parts per unit, down to like 2.5 parts per unit in terms of microns per micron-sized particle. Sorry, that was confusing. 10 micron-sized particles and smaller, down to like 2.5 size micron particles, are the kind that are most damaging to the lungs. And that particular matter can get all the way down to the alveoli level when they're that small. So the way that that's measured, and they try to scale out how much should be in the atmosphere, is by that level of 10 and smaller, and then 2.5 and smaller. So that particulate matter can be a conglomerate between different organic particles, like carbon, mineral dust, water, and all of the other constituents of other gases like sulfur and nitrogen substances that are kind of conglomerated together. So that's one that most of the research actually talks about. There's a few other ones that talk a little bit more specifically about certain pathways of disease and how they get to those. So I won't get into too much detail, but ozone at ground level, not up in the atmosphere, but O3 that's generated by a reaction between sunlight as well as the industry emissions and car emissions, creates ozone at ground level, which has a lot of pulmonary effects, and specifically asthma triggers in particular. And then nitrogen dioxide is the other one that's also particularly toxic to asthmatics and getting inflammation started in the body, and that's the other big one that tends to be produced. And then sulfur dioxide and volatile organic hydrocarbons are lesser players. So in general, the 2 big types of exposure that we talk about are like indoor and outdoor sort of exposures. So the indoor ones are used like cooking inside. So that's using a lot of solid fuels, things like wood, crop waste, charcoal. Interestingly, so while this disproportionately affects women and children who are working inside the home, preparing meals and doing those sorts of daily activities, apparently the levels of particulate matter and all of these aerosolized, very toxic compounds can actually reach levels 100 times higher than any of the other recommended outdoor sort of recommendations inside the home, since these like small dwellings with very little ventilation really set people up for that. So then the other part, the one that I'll talk a little bit more about, is the ambient and outdoor air pollution. And that really comes down to like every single area of civil engineering, from like transportation and what fuels are being used in cars, and the density of vehicles and what kinds are being used, urban planning, power generation on like a citywide scale, as well as industry in like the agricultural sense, and various municipal sort of energy and pollution creating stuff. So the slide looks really busy, but this is just kind of a general breakdown of all of the different places that that particulate matter and air pollution directly has been identified as playing a huge role. So some of the more obvious ones, like lung manifestations, you'd kind of expect people breathing in toxic stuff is going to have a lot of primary lung manifestations, and it's true. Things like asthma, COPD, pneumonia, and other respiratory tract infections are usually the most strongly associated with a lot of these things, as well as setting you up for having tuberculosis if you've got chronic lung problems as well, which we know is a huge burden of disease. There's also a ton of really fascinating data out there about air pollution and that particulate matter in particular really snowballing inflammation in general, which can actually lead to accelerated atherosclerosis and leading to heart attacks and MIs, and overarching like ischemic cardiomyopathy and heart failure. It has effects on promoting strokes and having CVAs. There's an association between accelerated dementia in these populations, as well as neurodevelopmental disorders in children. They've got associations from lung cancer, obviously, to nasopharyngeal, laryngeal carcinomas, and I found stuff on prostate cancer and childhood leukemias as well. And then otherwise also associations with low birth weight and diabetes. So not a lot of intuitive stuff on that. but find some really, really interesting associations. So there was a couple of things that struck me with a few of these things, and the way that a lot of this data has been gathered has been everything from basic science in the lab sort of studies, looking with mouse and animal models and stuff like that, down to like human studies and big cohort studies that they found a ton of these associations with. And then some of the more interesting papers that are really recently coming out are doing large-scale mathematical modeling on these sorts of changes over time, and looking at how a lot of these changes are shifting the burden of disease into other parts of the world that previously had not necessarily had to deal with these kinds of chronic illnesses. And one of the things that I found the most fascinating was that, like, as we've talked a lot about infectious disease here in these TTMS conferences and a lot of different things, one of the topics that's come up a couple times is the huge burden of non-communicable diseases that's becoming more and more prevalent in the developing world as it pertains to things like diabetes and heart disease and strokes and malignancies that are really difficult to manage in those settings. And at this point, there's a lot of shortcomings when it comes to dealing with those long-term chronic conditions that propose a very, very different approach and a very different set of problems than do a lot of the infectious diseases. This is my last slide, and there isn't a whole lot else for me to say at this point about the what's next, because I'm not really sure what's coming up next. So a lot of these things really are going to be in flux. There's all of the new climate change data. There's these new conferences about what the new changes are as far as the WHO guidelines go. And there's a lot of regulation, like in the UK in particular, about restricting NO2 emissions and trying to reduce that carbon footprint. And there was an article just last week about even all the way down to like streets, but there's a street in London that's already breached its annual emissions for the whole year in 1 week of 2014. And it's fascinating to know that they've got data down to the individual street level, because that's what ends up affecting populations, and it changes within each city between streets to the next street, from one city to the next, and then whole countries. You can see there's going to be a huge amount of variation and a lot of difficulty in analyzing the data from places that aren't reporting. But a lot of it really plays into like growth and development and the resources that all these developing countries are going to be able to use to manifest that. So I thought this was a interesting thing to see really where it goes next, because the most updated data from the WHO about air pollution is actually coming out in the next few weeks. And so maybe this will be a bit of an evolution in that and have a little bit more data on that scale. I know I did that pretty fast. Is there any questions that I can answer to my limited knowledge? Doctor?
Did you run into any data at the street level for the United States? I'm just curious.
So I actually didn't see a whole lot about the street level data for the U.S. I think overall, because the U.S. has a far smaller burden of disease when it comes to air pollution compared to a lot of other places, some of the street level data was coming out of places like London and other big cities in the U.K. And then they talked about more population level, city level stuff in places like China and India that have the highest burden of like dense cities with high urban populations and a lot of pollution, but nothing specific about the U.S.
I'm just going to guess that there probably is quite a bit of variability by street level.
Mm-hmm.
In some of our big cities.
Oh, absolutely. I would definitely imagine that.
Thank you.
Oh, sure. All right, thanks.
Thank you, Dr. Dallin. That was very interesting and useful. So next we're going to bring up Dr. Gores. What's interesting about Dr. Gores is he's working the night shift tonight. So I'd like to thank him first for taking the time to come speak to us, even though he had to sleep and now he has to work. I think this one fits a little bit better. So Dr. Gores is a third-year internal medicine resident, and he's actually going to be one of the global health chief residents for next year, which we're really excited about. And he will be in Arusha, Tanzania the second half of the year. Is that correct? Yeah. So he does his continuity clinic at Center for International Health through Health Partners. And he went to Uganda with the IOM. And he had some really interesting times there. So, yeah, we'll bring up Dr. Gores, and he's going to talk about Ebola and sepsis. Did I just give it away?
Thanks, Ryan. So as much as this case looks like Ebola, obviously it is not Ebola. But this is a case from the New England Journal of Medicine last year in December of 2014, about a 32-year-old returning from Liberia with fevers. So during this case, I just thought I'd kind of introduce kind of two topics during it. As much as this probably isn't going to be Ebola, if you see a patient from Liberia, from an outbreak area, chances are other people are going to have more common illnesses. But I do want to talk about the precautions you would take in an epidemic regardless, just to be safe, but also kind of at least my approach to a fever in a returning traveler. So just going over the kind of introduction, this is a 28-year-old who just spent the past 3 months in Liberia, experiencing fevers on the 8th day after his return to the United States. He really noted no direct exposure to folks with Ebola, and upon return to the U.S., participated in the routine 21-day observation period where he took twice-a-day temperature readings. And on the 8th day, noticed his temperature had increased to 39.3 Celsius with kind of new onset headaches and myalgias. So because he was undergoing this observation period, he contacted the appropriate EMS service, which came out and interviewed him in the field to see kind of his risk stratification for potential Ebola, interviewed him in kind of precautionary PPE, and then transported him to the hospital. So during the EMS survey, they found out that generally this patient was pretty much healthy, had just some minor injuries in the past, a notable dog attack about 6 years ago where he got vaccinated for rabies, as well as pre-departure evaluations and counseling prior to his departure, getting vaccinated for Tdap, yellow fever, and getting an oral typhoid vaccine. He noted he took daily doxycycline during his travel to Liberia and discontinued the medication on the day of his return to the U.S. Otherwise, he's a non-smoker, moderate alcohol intake, no illicit drug use, and is not currently sexually active. A bit about his travel history. He spent half of his time in Monrovia, which is the capital, right about here. So that was the only place that he was actually at with cases of Ebola. He went out to 2 sites that did not have cases. He was working as an administrator for an NGO that was working with Ebola relief, but had no direct contact with Ebola patients himself. He did not use public transportation, did not share sleeping quarters, he had no animal exposure, multiple mosquito bites, and maybe one friend who had a URI-like illness during the travel, but otherwise really was healthy the entire time he was there. He also notes in the past about 5 years he's had traveled to sub-Saharan Africa, specifically Kenya, as well as the Middle East and areas of Europe. So this deemed him at least high enough risk, just given his exposure, at least his travel to Liberia, to be evaluated at the hospital. So en route, the EMS providers just updated the hospital that they had a suspected case of Ebola, and precautions were just triggered based on the hospital's prearranged algorithm. So this is actually a Mass General. And upon arrival, he was placed in a negative pressure room for triage, and after further evaluation, was transferred to an area of their ICU deemed the biothreat care unit. So this was just a set-aside area of the ICU at the end of a hall where he would not be getting any other foot traffic or exposures, and was isolated to just a small pool of nurses and doctors. About 32 trained nurses volunteered to be part of this unit if needed to be activated, and about 16 doctors, where there would be at all times 1 doctor and 4 nurses who could care for the patient at any given time. In addition, just to limit any fluid contact, most of the diagnostics were taken inside the room with point-of-care testing. Any cultures that were obtained were specifically asked to be in plastic petri dishes or plastic containers so that there was less risk of breaking or sharp objects upon if anything were to happen. And any necessary testing that had to occur outside of that room had a very specific, structured supply chain to get it transported down to the lab and limit the amount of contact that it would come with. So just a little bit of a word about this. The staff at Mass General were kind of taking an amended version of the CDC's recommendations for how to approach Ebola, or at least a suspected case of Ebola, with the appropriate protective equipment. And this is kind of generalizable for anyone who's ever in an epidemic setting or seeing a patient who's coming from that area. So I just thought it'd be good to go over. So of course, you want to have adequate personal protective equipment, as well as an appropriate isolation area. And in any epidemic, if it's, say, in the community, you start off kind of broadly with your isolation if you don't know the underlying agent. So you do droplet, you do contact, if you're not really sure where this fever is exactly coming from. And then you can start to narrow that once the agent has actually been identified, either in that patient in particular or in the community itself as your suspect pathogen. Again, the other big part of this is actually just educating staff. I know at the university we had the very first icon up there as Ebola information, but also having staff ready to deploy in these situations, as well as just taking the necessary precautions in the field before arrival. And then finally, this is just a little bit about just the way it's approached, epidemics are approached. In general, a case definition is usually created to kind of give information in the field about public health surveillance for suspected cases. So for example, with Ebola, it's usually in folks who have traveled to endemic areas with notable fevers. But further, after that, they are then risk stratified. So high risk folks, specifically for Ebola, would be patients who have percutaneous exposure or exposure to mucous membranes, body fluids, exposure without protective equipment to the fluids themselves while the patient's symptomatic, processing these fluids, or just direct contact with a deceased person known to have Ebola virus, again, in an endemic country. But then there's lower risks, some risk, low risk, not necessarily zero risk, of patients who had direct contact with protective equipment, or in individuals who had just visited the country of suspicion. So our patient in this situation met low risk. And following this CDC algorithm, which, sorry, I'll zoom in here, we see that with low risk, based on clinical suspicion, this hospital could have chose to indicate for additional testing or opt out, depending on their kind of approach. But just being precautionary, they did decide to admit the patient, isolate, and evaluate for potential Ebola. So upon admission, this patient was notably febrile, hypertensive, tachycardic, flushed, and diaphoretic. And interesting enough, they couldn't auscultate because of their actual PPEs, but otherwise looked well, despite feeling just awful at the time. An initial diagnostic per the hospital protocol for the suspected Ebola showed that a patient was relatively well, aside from maybe an anion gap just around upper limits of normal and an elevated creatinine of 1.2. So at this point, again, our suspect is always to rule out something that would be from the epidemic country. We always want to make sure we're not missing Ebola or something that's transmissible to other people. But chances are likely this is not Ebola. And so I'd just like to build a differential here. And whenever I do this, I kind of go through a specific approach whenever I talk about a fever in a returning traveler. So there's probably a couple considerations to just factor in. First of all is patient factors, specifically areas of travel, exposures, what preventable measures they took, but also the patient themselves. A phrase I heard in the travel clinic was always, the most likely thing that you're going to get is what you bring with you. So a patient who's immunocompromised, who's HIV positive, who's pregnant, they're more likely to have complications of these issues while abroad than actual things that they're going to be exposed to. They're more likely to get in a motor vehicle accident than actually caused by more exotic illnesses. So just a consideration to always consider right up front about what is common in this situation and what illnesses are ubiquitous around the world. URI illnesses, influenza. But second, also to review the exposure history to assist kind of establishing an incubation period. Finding out exactly when this patient was abroad, when they could have been exposed, can narrow this. So if someone was abroad for a week, influenza might be more common. But if they were gone for a year and the symptoms are starting 6 months after they come back, TB might be within your differential. But it's just to give you kind of a way to narrow down on the exposure history and how long this illness could have been brewing. And then finally, to review actually the exposure in the specific areas these people had traveled to. While obviously there's regional differences between sub-Saharan Africa and Southeast Asia, also within a country itself you can see differences. If someone was in Peru and just in Cusco, they are less likely to be exposed to an arthropod if they were in the northern areas where there's rainforested areas where they could be exposed to malaria. And then also always just consider symptoms. If someone is anaphilic, that obviously creates a different differential than if there was a bug bite with a significant rash around the area. So this is all taken from the Yellow Book from the CDC. I just think it's a good resource for using this differential. You can see for specific incubation periods between, where they cut down between 14 and 6 weeks where people might fall, as well as geographic areas with more specific details about where they could come from. So it's just a good resource, and it's online if anybody wants to use it. So using this for our patient, I thought it'd be good to kind of use this kind of almost Venn diagram-like way of narrowing a differential. We can create a differential based on where this patient was, how long his incubation period was, and where symptoms were, and then eliminate things that don't seem to fit with each of those. So using that map from the prior study, I'll just kind of pull out things that they have listed as incubation times less than 14 days. Now this is just to say that he left 8 days before, so these are things within the differential. But again, he's been there for 3 months, so that definitely does add to things within this differential. So we can add things that were actually beyond 6 weeks just because he was there for a longer period of time and may have some latency in its exposure. So this is not an inclusive differential. Obviously, there are broader causes of fever, but these are just some considerations to take into effect. But then now taking that next layer about where he actually was. So this is a map of where malaria has been endemic in the world, and we do see that that's within our differential. We can look at, I believe this is dengue, and see that he's been in endemic areas for this as well. And finally, yellow fever. And we can see this, and I'm sorry I didn't have a map for each one of these illnesses, and realize that he's not in areas where something like Japanese encephalitis would be common. And in fact, his symptoms alone probably does not even include encephalitis within the differential. And then going again, now next to that next layer of just symptoms, he's not really endorsing any abdominal pain or diarrhea to endorse enteric fever, or more likely constipation. He was not sexually active or exposed to bodily fluids, so just making that less likely of HIV. And again, not having any abdominal pain, not having any jaundice makes these causes of liver disease less likely, and without any exposure to the water or any rash, less likely it's acute schistosomiasis. So while this doesn't eliminate these as factors, I think it just stratifies what's more likely in his differential and can raise causes of fevers with more generalized symptoms within our differential. So finally, going back to our case, we can get initial diagnostics from those prelim just hospital policies. See that he had negative blood cultures, obviously a negative Ebola screen, and a positive rapid test for P. falciparum. So this was actually obtained within an hour of his arrival. But again, it took appropriate precautions to make sure that this wouldn't be something that was more of a danger to the staff. But there is a bit of a twist. So after getting appropriate therapy and IV fluids, he was afebrile by day 3 and released from isolation on day 4, completing his 21 days for completion's sake of the Ebola screening. But in 6 weeks later, he had recurrence of the fever, and he actually when he came back in for evaluation, was positive for non-falciparum malaria. They never actually were able to speciate this, and they did treat with primaquine this time around. And there was a bit of a theory going within the paper itself that he had exposure maybe during his last year to travel to Kenya to something like Vivax, and that there have been case reports of reactivation of latent Vivax with treatment of falciparum. So really, just some take-home points. Always just to be prepared. You can be prepared for situations with epidemics. Even though it wasn't Ebola, you want to take your precautions, or anything communicable that could have been spread around to the hospital, to patients, to staff. but also just being aware of what your resources is, going to the Yellow Book and using whatever method you'd like to approaching a fever and returning traveler, just to be ready with that kind of your own algorithm, your own method to approach these patients to kind of get them back on their feet faster. So with that, I'll just leave it open for any comments or discussion. So.
Nice presentation. So the question is here, like in US or in your institution, is the artemether standard of care for the malaria? Because I'm curious, just in Thailand, they had some issues related to the quinine resistance. That's why they started artemether. So I'm curious to know that part of world, the Liberia part, do they use artemether? Because have you shown that the patient has recurrence? And then the usual protocol, like I'm from Bangladesh, we have set quinine plus primaquine. And almost, we didn't see any resistance. But some of the reports said that in Thailand they have found, but there was a study, WHO funded, they have clearly shown that most of the cases, artemether, they don't need it at all. So I'm curious.
Yeah. Well, I do know that in areas I've worked, at least in Uganda, there was two. They left it up to availability. There was quinine therapy, and then there was artemisinin-based therapies. And again, it always is based on availability in those countries. And I believe here in the United States, and I would love someone's input on this. Usually, those medications even have to be requested. They're not usually readily even available within our hospital formularies. So, if anybody has some comments on that.
Oh, I can comment on it, Matt. So Coartem orally is available in the United States. The IV form you have to get from CDC. You have to order it. And my guess is they could have done PCR on this to speciate the non-falciparum. Most likely, just given he's from Liberia, and I didn't follow his travel history specifically. What was his last country of?
So he had been to Kenya in the year before.
Okay.
And he's actually from Massachusetts. So he was traveling to Liberia as a part of the relief effort.
Okay. Because you find Ovale in Liberia as well, so that would be another possibility. And I think the epidemiology as far as resistance goes, there's been a handful of cases of resistance to artemether. Those have been on the Thai-Burma Laos border. There's only been a few of them, and there's been a couple of documented ones in Africa. It's hard to document those because you actually have to not only have somebody say they're on it, you have to document that they have a serum level that's high enough. It's still thought to be, particularly in Africa, fairly rare. Whether or not it's going to emerge is hard to say. And then the last thing is, just for people who don't do a lot of malaria, what we're kind of assuming people know is that there's the liver form, the hypnozoites, and that's the Vivax and Ovale that have that form, and that's the form that you need the primaquine for. So if you're only treating for falciparum or P. malariae or Knowlesii, you only need the blood treatment. You still can get failure or relapse, and sometimes it's not actually. We've seen people fail therapy, but because they were malabsorbed, they did malabsorbed or something like that, so it wasn't actually true resistance.
Yes, sir.
Liberia regularly uses for treatment of malaria a combination of amidiaquine and one of the artemisinin drugs.
This patient was treated at Mass General, so I can't speak to their formulary or what availability they had initially. But it's interesting. Thank you. Okay. Thank you again.
Thank you, Dr. Gores. Did you take the speakers? Very good case, Dr. Gores. Good reminder to not have early closure on cases we think we know the answer to. Also, I forgot to mention, if you do go to that Twitter page, all of the articles are linked there. So you can follow along the articles and look at the figures and things like that. So another reason to join Twitter. The next speaker we're going to bring up is Elizabeth Gullin. So she's one of the chief residents at Regions. And she's been doing a lot of great tropical medicine teaching over there, which is awesome. And she's going to go into infectious disease. She matched at University of Virginia. Some other interesting things. She was studying leishmaniasis in Honduras. So you can tell us about that later. And you rotated in Nepal as a resident. So great. So have you come up, and I think this is your presentation.
Okay. So I'm going to review actually one of the New England Journal articles that came out, I think it was in November of this past year. Like in medicine, we like to start out with a case. So this case was a 43-year-old Colombian gentleman. And actually the article didn't really say a whole lot about him, just the fact that he had presented in Colombia to a local primary care provider and had noted several months of fever, cough, and weight loss. And notably, he did have a history of HIV, but was fairly non-adherent with his medications. And there was a recent CD4 count, which was 28, and his viral load was about 70,000 at the time of presentation. So as you know, this is not an uncommon presentation of a patient in Colombia. And so as a chief resident, we like to spend a lot of time building differentials. So I thought we could kind of go through a few basic things if you want to throw out some things that they would be thinking about if they saw this patient coming into their clinic, say on an international rotation. Yes, so TB in our HIV patients. Absolutely. That's the other big thing we tend to think about a lot. Cancer. So not just infectious. I love infections, but we need to make sure that we're not missing out on other things that might be going on. And are there any other exciting things we could be thinking about? So he's in a tropical. Exactly. So that would be here and also tropically. So atypical mycobacterium. And then I spent some time just putting together, other things that we could be thinking about too. So we already highlighted that TB and PCP would be two of the big things we'd be thinking about. But keeping in mind that there's also all sorts of other fungal infections, there's viral infections, and now we're getting kind of into parasitic territory where we should make sure that that's in our differential as well too. And then we've already mentioned that non-malignancy is pretty important to rule out as well. And our HIV patients are predisposed to various malignancies. So this could be anything from Kaposi's to a typical lung cancer to lymphoma. And then even remembering that there's other non-malignant, non-infectious things that could be going on. So this patient, since he had a cough and fever, ended up getting a chest x-ray, which was pretty remarkable, as you can see. So he had numerous lesions throughout his lungs, and at that point in time, they really wanted to go for further workup. And then they also ended up, just for kind of a complete workup of an HIV positive patient presenting with fevers, they got some stools. And for those of you taking the tropical medicine course, I don't know if you guys can remember the identification of all of these eggs that we're seeing here on his stool. So can anybody tell us what the top one is? So that one's Haemonolepis. And then what about this one? So that would be Blastocystis. And so we actually got 3 days of albendazole for treatment, which would potentially target the Haemonolepis, maybe not as much this guy. And then he was in a fairly big city and did have resources to get a chest CT. So got a CT of actually his chest, abdomen, pelvis, which the article highlighted this chest CT. You can see that there's numerous masses throughout his lungs. In the article, they also highlighted, so not only were there masses in the lungs, but there also ended up being masses in the liver and then the adrenal gland. and then the green dots are the lymphadenopathy that he had developed. So he had cervical, mediastinal, and then abdominal lymphadenopathy as well too. So like all good doctors, they did not let tissue get in the way of a diagnosis. So they ended up getting some biopsies. And the biopsies were from the cervical lymph nodes, and then they actually also biopsied some of the lung lesions as well to see if it was correlating. But they did not actually have all of the diagnostic techniques down in Colombia that we do up here in the States. And so at this point, they contacted the CDC and they asked if they could send up some of the tissues for more thorough evaluation. So these are some pictures of the actual slides that were taken and sent to the CDC. And so the important things are, so these are the cells themselves. It's kind of hard to appreciate, but these cells here, they represent very small cells. So these are actually smaller than red blood cells. And they had pretty high nucleus to cytoplasmic ratios. And then there were several that had some high mitotic activity and a lot of nucleoli. So this is a bigger cell and it had a lot of nucleoli in it. And then the electron microscope actually demonstrates a lot of mitochondria throughout the cell. So this cell actually looked pretty different from human cells. And even more so when they actually took a step back and looked at how the cells were interacting. So the one thing they noted is that these cells were acting almost in a malignancy fashion. So they were invading tissues and there was actually necrosis. This doesn't show you the necrosis, but they found pretty extensive necrosis throughout a lot of the tissues. And then this here actually shows the formation of syncytia, which is basically cells that have fused together. They have multiple nuclei, but they look like they were individual cells at the beginning, and now they've all fused together to form one giant cell, which is another thing that's pretty atypical of human cells to do. So at this point, they actually had kind of reached a conundrum where they said, on one hand, we have this invasive cells that look like they have necrosis, look like they're dividing, they maybe look cancerous. But on the other hand, the cells didn't really look similar to human cells. So they noted that it was very small and that it was pretty atypical size to be a human cancer cell. The syncytia formation is something that's not very typical. And then they also noticed a few other things that seem pretty typical of a more primitive appearing cell. And so the question was, was this a human cell or is this something else that we're dealing with? So they decided to delve a little further to try to figure this out. So first thing they did was got cultures, and the cultures ended up being negative. So they kind of had to move on from there. And then they started doing some DNA analysis of the tissue, and they found out when they actually started analyzing for maybe some mold or some parasitic DNA that there was some Homonolepis DNA in that tissue that was biopsied. So then, of course, the question is, are those invasive patches of cells, are those directly Homonolepis cells, or is the Homonolepis somewhere else in the tissue, and as we extract the DNA, that's what we're seeing? And so then they did some immunohistochemical staining to look at how the cells lit up underneath the microscope, and they found out that actually those invasive cells were of cestode origin as opposed to human origin. And so then they felt like they had pretty much confirmed that this was probably Homonolepis cells that had this malignant type transformation. So they decided to sequence the Homonolepis DNA and compare it to known sequences before to see if there were any gene insertions or deletions. So when they did that, they actually found out that for the most part, the Homonolepis in the patient had was pretty conserved across all of the portions of DNA, with the exception of 6 regions. And those regions ended up being pretty important. So 5 of them were associated with protein coding genes. 4 of them had some differences in how they were expressed across adult versus larval stages of the parasite. And then 3 actually had some homologous genes that have been studied in human cancers. So the theory was that maybe this is some gain of function mutations associated with protein coding that had led to this patient's presentation. And so obviously the patient is still waiting in Colombia while we're analyzing all this tissue. So while that's going on, the patient was started on retroviral therapy. About over the course of the next 4 months, while we were waiting for the results, his lymph nodes continued to enlarge, which is not surprising if this is parasite tissue. We haven't really treated it at this point in time. And then he actually, unfortunately, subsequently developed histoplasmosis and got some amphotericin B, which led to renal failure. And he ultimately decided to not go on dialysis, and palliative care was initiated. So the results actually took that 4 months to come back. And so they came back about 72 hours prior to the patient passing away. Although it did sound like from reading things that they were able to tell the patient that they had figured out what was going on. So he did know that, they were able to diagnose the cause. And so I wanted to review a little bit of hematolepis specifically. Its more typical presentation, and then I'm going to talk at the end kind of about this atypical presentation and what we think was going on here. So for those of you guys who do not remember everything about parasites, we don't spend a lot of time thinking about this, but in human parasites, we tend to divide kind of into 3 big groups. So we have our protozoa, our arthropods, and then our helminths or our metazoa. And so we're in this group over here, the cestodes or the tapeworms. And so hematolepis is in that category, kind of Diphyllobothrium and other tapeworms. So it's found worldwide, everywhere from Russia to Australia to the tropics. And the hosts, so this is a little bit unique, and we'll talk about this with the life cycle, where humans are the definitive host, and we don't need an intermediate host. So this is one of the few parasites where you get auto-infection over and over again. Mice and rats can also propagate the life cycle, and then you can also have lice and beetles that are propagating it as well, too. So to go through the life cycle briefly, so what happens is a human ingests an embryonated egg. This is what it looks like. The other thing that can happen is sometimes the eggs can be ingested by beetles or lice that can contaminate various grains. And so people or rats can ingest that as well too. And then once the egg is ingested, it turns into a cysticercoid, so it hatches, and it actually goes inside the villi at that point, the villi of the intestines, and then it matures in the villi after about 4 or 5 days. And so once it matures, then it actually erupts through the villus and it destroys the villus, and it turns into the adult form where this scolex will go ahead and attach onto the tip of the villus and get nutrition through that. And then with this, as I mentioned, you can either get auto-infection where the eggs are released into the intestine and you can complete the cycle, or kind of through fecal-oral transmission, it can be transmitted from person to person, which they think is the most common mode of transmission. So this is actually a disease that primarily affects children. We don't see a lot of issues with adults with this, and it's primarily endemic in developing countries. So typically we would see the more intestinal form of the disease. Most people are pretty asymptomatic, but if you checked a stool sample in people in developing countries in crowded conditions, poor sanitation, a lot of people will end up having this in their stool. Some people can go ahead and develop more of an enteritis-like symptoms. And then there's more and more data that's coming out that actually chronic infections are associated with poor growth and anemia. And often there's co-infection that occurs with other parasites that also propagate this. They've actually looked at some studies, I think it was in Australia, Egypt, Ethiopia, and Mexico, that show that in growth-restricted children, up to about 30% of kids will have this infection, as opposed to their age-matched healthy peers, where only 5%. You can see the hematolepis in stool. There are a few case reports of extraintestinal disease, but these are more on the case report side of things. So in HIV patients, there's been demonstrated an invasive cystic form of the disease. And there was a child who I believe was in Egypt, if I'm not mistaken, who got some steroids and had malignancy, and they found the cysticercoids in the child's blood. But with this, it was actually pretty easy to diagnose because when they got the biopsy, the cells looked very similar to typical cestode cells. And so the treatment, the preferred treatment would be praziquantel. There's some alternate agents. And then if they have tissue invasive disease, so if they have the extraintestinal disease, where you really want to target the cysticercoids, then you can consider albendazole. And something to bring up here is, so a lot of the deworming campaigns have been very successful with more of our roundworms. But with this, you can see that albendazole is not our drug of choice for hematolepis. And so there's actually been much less successful eradication of hematolepis in children throughout the world since albendazole, I think they said about maybe more like a 70 to 80% eradication rate, as opposed to kind of 80s to 90s for a lot of other worms that we deal with. So with our patient specifically, he had a very unique case where he had this transformation of his parasite into kind of almost a malignant-looking tissue. And so this is the first time this has actually been described in a multicellular parasite. So there's a lot of theories about why this happened in this specific patient. Most of them involve the fact that parasites require interaction of the host immune system and the parasite itself for appropriate development. So it's really that interaction that leads to the life cycles that we know. So the theory is that in this patient, he's immunosuppressed. He doesn't have the typical interaction between host and parasite tissues. And actually in this type of parasite, really their germ cells are the only cells that are replicating and dividing. So it's not their differentiated tissue that's able to divide, it's those initial stem cells. And so probably the parasite stem cells ended up replicating, dividing, and you had preferential selection for growth and proliferation, which led to a disseminated cancer-looking entity. So since this is the first time we've described it, we don't really know what we are going to do to treat it if this happens again. Albendazole doesn't really work on the germ cell forms of cestodes. There have been some preliminary studies that show that it has very little effect on this. So there's a question about, what should we use to treat a patient if they come in. There are some novel agents. So specifically looking at, I think, Echinococcus cells to see if they could target those initial germ cells, since that's what seems to be growing and propagating. Most of this is all in vitro and has not been transferred to in vivo studies yet. So it's still in its infancy. So the implications are, in HIV patients, we always think about atypical types of infections, but just keep in mind there are probably things going on that we don't know. And so especially in developing countries where we don't have all of the fancy diagnostic capabilities that we do here in the US, we might be missing things like this. So with our patient, is it a cancer? Is it a slime mold? In this case, it was a super parasite. So keep that in mind. And those are my references. And then any questions that anybody has?
Has that malignant transformation been noted in other parasites?
So this is the first time they had noted it in multicellular organisms. There have been some unicellular organisms that have had similar transformations, but this is the first time that we've had like a human described with this. That I did not look into. I'll be honest, I wouldn't be surprised if there was. Yeah, I know a lot of times, so treatment is controversial whether or not you need to treat people with it. And a lot of times we end up treating our HIV patients because there's been described, the dissemination in HIV patients. And I don't know the direct correlation between CD4 count and infection rates. Mm-hmm. Yeah. So that does pretty well. That's in the mid to upper 90%. Yeah. And those are more for the intestinal forms. So if you have invasive forms, then you do also use albendazole as well too. Okay.
Thank you, Dr. Gilleen. That case is incredible. Sounds like one of a kind, or maybe it isn't, but I guess we don't know. So the next speaker is David Flood. So David is a first-year MedPeds resident. So he worked in Guatemala with an NGO there. I don't know, how long did you work with them, David? A few years. That's great. So, yeah, you've worked on a lot of projects in Latin America since 2008. That's what this says. So, and he'll be presenting on scabies.
Such a hot topic right now. Hello. So my hot topic is scabies. Can you guys hear me okay? All right, so this is a patient I saw in early 2014.
her mom did give us consent to take her photo, by the way. Her name is Jocelyn, and she came to our clinic. I saw her with my preceptor, and she presented us the day I took this picture. It was the third time that she had come with just a lot of itching at night. Her whole family was itching. It was pretty obvious that the diagnosis was scabies, so it's not going to be like a mystery. But we had treated her with benzoate, which is kind of like the locally available topical treatment for scabies. And it's kind of a pain in the butt because her family, I think they had 8 members in the family. They lived all in 2 rooms. This is her home in the background. It's out of cinder block. And it just didn't work for her. And so with one of my Guatemalan colleagues, we looked around for oral ivermectin. We were able to find a generic supplier, and we ended up buying it. And we treated her and her family with ivermectin, and she actually got a lot better. And I saw her again 3 months later, and she still had some hyperkeratosis, but she wasn't having any active inflammation like her skin. So I was really proud of myself, and because now we had that drug on formulary and we could use it for lots of patients. But we were only giving it to people who presented with a diagnosis of scabies, and so and we were working in a highly endemic area. So that's kind of my teaser. So this is scabies. It's a mite, and I guess the genus name is Sarcoptes scabiei. Yeah, you guys probably know more than me about this particular guy. Basically, it's annoying because these little mites burrow into the very top of the skin, the epidermis of the skin, and cause kind of just a local inflammation. And as I'll show in a little bit, it's not only kind of annoying and can cause sleep disturbances, but it can actually kind of serve as a nidus for bacterial superinfection, either with group A strep or staph. Can cause impetigo, can cause rheumatic heart disease, post-streptococcal glomerulonephritis. So that's kind of why people care. Some of the things I learned while kind of preparing this case are that when I hear scabies, in the emergency room, people go crazy. But it turns out that it's actually not that easy to get transmitted. And an immunocompetent person with scabies usually has between 10 to 15 and 100 mites on them, so actually not that much. And you have to have very close, intimate contact. And so, being in a room with somebody you're not gonna get infected. They don't jump. They move very, very slowly. So they're not actually that infectious. But except when you have people who are immunocompromised, they can get this specific kind of scabies, Norwegian scabies. Probably some of you have treated that, which is much, much, much higher burden of parasite. And those are much more infectious. This is a histology specimen. You can kind of just see here in the cut that this little scabies, little guy kind of in the epidermis, a lot of eosinophils, just kind of causing this local reaction. And you can actually see kind of how it opens up the skin, maybe to entry for bacteria. In my understanding, the diagnosis of scabies is mostly clinical. There are, you can use you can take skin scrapings and look it under the microscope. You can take Scotch tape and look it under the microscope, or you can use a dermatoscope if you're a dermatologist. But I think mostly people diagnose it clinically with the characteristic lesions, which I'll show in a second, especially the location on the body, kind of between the digits, in the groin area, the wrists, kind of around the umbilicus. And I think in high-risk groups, so maybe in Minnesota, I was just talking to one of the EM docs at Hennepin County, and they see it. People who stay in shelters tend to be a high-risk group, or in high endemic areas in global settings. These are kind of just some photos of the lesions themselves, kind of these little red papules, pretty itchy. Sometimes they're kind of in a linear pattern, especially kind of in the distribution of them on the body, kind of is a giveaway. Oh, there was actually, somebody did a study, I think it was in Fiji as well, showing that the presence of lesions in 2 locations, 2 of these typical locations on the body, or similar lesions on any other member of the family living in the same home had 98% sensitivity and specificity. So I think in highly endemic areas, just knowing what they look like and knowing where the lesions are is it's not too tough of a diagnosis. And in terms of like why we care, I guess, like I mentioned to you, kind of the itching and scratching, that's kind of one problem. Yeah. It causes sleep disturbance. They say economic impact here. The crusted scabies, that's kind of the, in people who are immunosuppressed, they can get much worse scabies infections that requires much more intensive therapy. But I think people really care because of impetigo and because of all these other kind of like bacterial effects that you can get, bacterial superinfections. Has anybody used the Global Burden of Disease Data Visualizer before? Yeah, it's pretty fun. This is the scabies one. I think it just kind of recapitulates the same map that you get with every single disease, basically. Every single like infectious disease, which is that the equatorial areas are always like lighter colored blue or yellow or red, and like the northern and most southern countries are darker blue. But anyway, that's just kind of a cool tool. This is the scabies map that they give. I mean, I think there's a limitation to maps like this. Like, I don't know if they know the scabies burden in every single country that they're plotting here, but nevertheless. And so this alliance, this like Global Control of Human Scabies Alliance, released this kind of viewpoint in 2013. And last year in 2014, scabies was actually declared a neglected tropical disease, I guess, which opens up different kind of funding mechanisms and forces the WHO to come up with like a plan for eradication and so forth. And this guy right here, who is the corresponding author, Andrew Steer, he was the PI for the study that I'll present in 1 second. So how many people have seen this abstract or title come through their email? So this just came out last month, so it's a hot topic. And basically it was a community-level randomized control trial for mass administration of oral ivermectin, that was one group, of topical permethrin cream, or standard of care. And I'll go through kind of the design in a second. But basically the idea, I think these people aren't really just like scabies experts. This is kind of maybe cutting to the chase a little bit, but I think one reason I like this study was because it was just, I think, a bunch of people who saw a lot of scabies, and they're like, we need to like do something about this. And they kind of took the leap from where I was, which is like, sweet, we have ivermectin to like, let's do a study to like systematically eradicate this like parasite that we have in our island. So that's kind of why I liked this study in particular. So this is Fiji, this little circle here in the very large Pacific Ocean. And the study was really elegant. It wasn't cluster randomized, but rather each of these sets of islands, like this blue set right here, these two, this yellow one and this red one, were each of one of the three arms of the trial. And so one group of islands, or one island, received the standard of care, which was permethrin cream upon a clinical diagnosis. One group received mass, basically everybody on the whole island was offered permethrin cream. And then the third group was this ivermectin group. So everybody on the island were offered ivermectin. The limitations for this were that pregnant women, as well as people under 15 kilos, were not offered. And basically they measured it's very simple. They just measured the prevalence at baseline, then they measured the prevalence at 12 months, and they saw which had the greatest relative risk and compared the different islands. So this trial was funded by the government of Australia, but it wasn't like a super complex cluster randomized trial that needed like a bunch of statistical modeling. Like, it was relatively straightforward, I think, and I think that contributes to its elegance. So I'll just run through the numbers. This is just kind of like the money table from the paper. So they diagnosed scabies, the baseline data. It was all clinical diagnosis. There was no microscopy, no, nothing. It's just people. It was actually, there's only one nurse on each of the islands. So that person was the person in charge of diagnosing scabies. And I think they get really good at it. They had published prior literature kind of validating the scoring system they developed for scabies diagnosis. But, their baseline data is pretty impressive. I mean, in the ivermectin island, basically, 32%. In the permethrin island, 42%. So, between 30 and 42% of people had scabies at baseline. And then that was reduced to these figures. Basically, the take-home message is that the absolute reduction in scabies in the oral group, basically, that the mass administration of oral ivermectin ended up being like a 94% relative reduction in prevalence, which was statistically significant compared to the permethrin group. And so basically they're arguing maybe like other analogous diseases, giving albendazole or mebendazole for worms, for giving azithromycin for trachoma, and for giving ivermectin for other things like river blindness is one example. Like maybe we should conceptualize scabies in the same way, and we should just have in areas that have high prevalence rates, like we should just treat people as opposed to trying to clinically diagnose them because it'll be more efficacious. And they postulated that the reason that at the community level that the ivermectin was so much more effective, even though randomized control trials in the past have shown that permethrin is as good, if not better than ivermectin, that the ivermectin was so much more easy to use. And there was 2 doses at time 0 and at time 2 weeks, and that the relative ease of use facilitated its acceptability, basically, is their hypothesis. So my 4 take-home messages. 1, I didn't know that scabies had been classified as a neglected tropical disease. I think it's kind of cool. For me, clinically, it's not all about the direct irritation of this little mite. It's about kind of the opening up for other bacterial infections and the sequelae of those. Although topical agents, permethrin or benzoate, work in individuals, that it seems like this is pretty convincing data to me, at least, that oral ivermectin given at a community level is probably more effective in groups. And it's just like a nice example of simple and meaningful global health research. It's not astonishingly complex. You can read it in one sitting. You're like, okay, yeah. So I thought that was kind of cool. That's all. Yeah.
At the ASTMH this fall, they had did anybody go to the talk on mass drug administration and scabies? Were you there, Bill, at that session? I wasn't there. I heard Pat talking about it, so this is secondhand information, but they were talking about there's some theorizing that some of the success of mass ivermectin campaigns in onco eradication is due to the fact that people were being treated for scabies at the same time, and it made the uptake of ivermectin really, people, were really taking the ivermectin because they stopped itching rather than because they were concerned about onco. And so it just helped promote mass administration. So really there's some thought that treatment is helpful. I mean, it was helpful in eradicating onco from some places.
Okay.
It's just an interesting
That's interesting. That wasn't mentioned in the editorial or the discussion.
I mean, it was more of an indirect
something permeating through the
it was
conference.
Interesting.
That's very interesting. Yeah.
Yeah, just along those same lines. So, refugees now, for the most part, depending on where they're coming from, are getting ivermectin pre-departure, and that's for strongyloides. And the WHO is also looking at doing that. We're doing that for refugees coming to the United States, but it's not a broad program like the mass drug treatment for schisto and soil-transmitted helminths. But they're looking at doing ivermectin more broadly. So beyond just places where there's onchocerciasis to places where there's strongyloides. And we've actually had this question whether or not we should look at scabies. For us, though, we just haven't figured out a good mechanism to do it because it's not easy when you have a mobile population to get people, because you kind of want to have the same person examining them and stuff like that. Yeah. But it's come up as an issue that would be interesting to look at. Pat Lammy, who was on that article, and this is where one place we've talked to him, actually has, and I don't know if it was mentioned in this article, there's actually a serologic test now for scabies. And so CDC's
I didn't see that mentioned.
Yeah, it's not being used diagnostically, but for this kind of serologic testing for scabies.
Interesting. I have a question for you, maybe. When you dose ivermectin, are you using the per kilogram dosing,
Yeah.
even in adults?
Yep.
Okay.
Although you usually round it because
Okay.
they come in 3 milligram tablets, so you usually round it
You
because
just
it's
round
usually
it, yeah.
3 or 4 tablets.
Yeah. Okay.
Yeah, but we do it per kilogram.
Okay. Okay. Great. Thank you.
Thank you, Dr. Flood. Hopefully no one else is feeling itchy after that. So our next speaker is Clara Peterson. So she's a second-year MedPeds resident. So she grew up in Rochester, Minnesota, went to Georgetown, and she minored in Spanish. So she has worked before in Mbale, Uganda, and Ecuador. And now she's working with a lot of immigrants and refugees at the Cook Clinic. So she will give our next topic. But it features a local celebrity.
Do you just hold this? Yeah? Okay. Okay. Oh, it clips? I don't know how it clips. Okay. Oh, no, that's cool. I need to be like an MC. Oops. You guys can let me know if you can hear. So my talk was looking at using sunlight as a form of phototherapy when it's filtered. And I took a look at an article that was by Dr. Slusher, one of the pediatric faculty who works at HCMC, and spends a large majority of her work abroad and really focusing on hyperbilirubinemia in infants and jaundice. And, you know, for this study, I think when you think about using sunlight, it's kind of funny. It makes you think of California and an integrative medicine center and being all zen. But actually, the study takes place in Nigeria. But maybe someday California will want to use the green side of this too. Some of my objectives in this study are to be able to recall the clinical impact, the presentation, and then really briefly just jog your memory of the pathophys. And since lots of you are internal medicine and not peds, maybe this will be like a second refresher about hyperbilirubinemia in babies and not in other adult manifestations. And then to understand the results of Dr. Slusher's study with her other colleagues she collaborated with and the significance of that. And then to recognize the strengths and weaknesses of using filtered sunlight as a form of phototherapy for infants. And then finally, I think this study is kind of interesting to imagine the possibilities of what we can do to harness sunlight as a form of energy and treatment for diseases. And it kind of reminded me, I was imagining Dr. Slusher giving a TED Talk about this study while reading the paper. So who knows, maybe someday. So first I just wanted to talk about the scope of neonatal hyperbilirubinemia. It affects over 481,000 infants worldwide. And out of those infants per year, 114,000 die and more than 63,000 are left with severe disabilities. So that's a pretty big scope when you start to think about things. Moreover, like a lot of diseases in David's map, maybe like scabies, it tends to affect low and low middle income countries. Highlighted in orange are the low countries by income, largely in sub-Saharan Africa, and then the tan are lower middle income.